I am just a doctor. I'm not a policymaker. I'm a Wahoo ×2, having gone there for undergraduate medical school, did my orthopedic surgery training at Wake Forest, my hand fellowship at Tufts University in Boston. I'm a former orthopedic chairman. I've been a member of the Quality Committee, Credentials Committee. I'm currently a medical director of hand therapy, and I'm a member of various organizations there, most notably representing Government Affairs Committee in the American Society for Surgery of the Hand, and I'm president-elect of the Norfolk Academy of Medicine. But if any of you saw Speaker Howell's recent editorial, he is highlighting several of these. And this is what we need to do. Not expand plus reform. We need to see that the costs go down and the care goes up before any expansion, period. Number one, the more we can get the federal government out of the way, the better. And in a perfect world, it'd be nice to have a block grant from the federal government. Here's your money for Medicaid per patient. Do with it what you will. Because every state has different requirements. They have a different patient population. And frankly, they have different ideas. And that's where our best ideas are going to come from the state's laboratories, not from the federal government. We should not take any new federal money. And we need to figure out how to get help to those that need it. Because there's a lot of people that are getting help that don't need it. I'll briefly go off track just to give an example of this that I did present at the Merck Commission, where a friend told me about her friend. She had a friend who lived, it's in North Carolina, it's not Virginia, but I'm sure this could happen in Virginia. There's a woman who lives in North Carolina. She's very well off, many acres, has a plane. She renovated a $400,000 home on her property for her daughter and her daughter's husband and their two children. One of those children had special needs, had a disability. So the husband of the daughter, who was living in the renovated $400,000 home, the husband didn't work. He just, didn't feel like working for whatever reason. The daughter got the job of her dreams, and she was making $70 more per month than would qualify her for Medicaid. So they don't have insurance. She could drop her hours or pay to qualify for Medicaid. She's living in a $400,000 home and has a mother whose net worth is several million. Is that right? So we need to figure out how to get the help to the patients that need it, with targeted subsidies, with fraud commissions. So if there are people who are receiving benefits that shouldn't, we need to save the money and give it to those that need it. And welfare-style work requirements would also help. We need to empower patients, and we need to provide compassionate care. We need to expand our options for a Medicaid patient. So what I mean by that is, one example is, each patient could receive X amount of money, and they can either get Medicaid or they can use that money to go out into the insurance marketplace and purchase a plan. Patients need to have skin in the game. They need to have a copay. They need to have a deductible. It doesn't need to be high, but they need to think about the money that is spent. And the only way they will think about the money that is spent is if they're spending some. And we need to expand free clinics, because that could be a wonderful way to encourage charity and to provide care. We need to have cost control, which means capping the total expenditures. We need to use a defined contribution rather than a defined benefit to help control the costs. These are things like HSAs, providing catastrophic coverage, no borrowing by Virginia for this. And I just want to touch on what a couple of other states are doing now. There's a lot of ideas out there, but I'm only going to touch on two. In Indiana, they had something called the Healthy Indiana Plan, and patients were required to contribute no more than 5% of their income. They're on Medicaid, and the state would supplement that amount up to $1,100 and put it in an HSA for them. And what Indiana found after 5 years is they were just hoping to be budget neutral, and they saved $1 billion. and there was no change in health. There are ways to do this other than creating an increasing dependent population. In Florida, what they're doing there is they're providing their Medicaid patients with a variety of different plans, not just one Medicaid plan for all, but they have a Medicaid plan if you have, for example, diabetes. They may have more than one plan that you can choose from. And they're bringing in the private insurers. This is helping drive down the cost because there's competition for this market. They're also trying to work on more community-based long-term care, because long-term care is a big component of Medicaid in nursing homes. They're trying to transition more patients out of nursing homes and either into the home or into community centers. That's saving money too, and it's not compromising health care. That's the important thing.